Okay, thank you. So we've gone through all the diagnostic techniques, and the question now is what do we do with the information that we have? We need to, of course, go ahead and choose the treatment that we're going to select for a particular patient. So we would choose our antiseptic or our antimicrobial, whether that be topical or systemic, usually topical in these cases, based upon the results of the cytology initially. And to do this, we need a good knowledge of the drug spectrum. So we need to identify whether the bacteria we're dealing with is gram-positive or negative, whether it's aerobic or anaerobic, and then we need to know which antimicrobials and which antiseptics cover those spectrums. In some cases, we will have ordered a culture, and while we wait on the culture, we'll have the animal on our initial treatment. When the culture comes back, we'll correlate the results of the culture with our cytology to determine whether the culture is accurate, and we may need to change our treatment from there. And we really want to, of course, avoid missing underlying causes that's contributed to the development of the derm condition in the first place, those being most likely Demodex, but allergies are certainly significant, and of course neoplasia should be a factor as well. When we're talking about selecting treatment for otitis externa, we tend to grade ear infections. So a grade 1 is a waxy discharge, mostly yeast on cytology with the occasional cocci. Grade 2 is a waxy discharge as well, but there'll be significantly more bacteria, so mixed cocci and yeast. If we select the wrong antimicrobial for these cases, then the cocci can quickly take over and develop into a grade 3 or grade 4 infection. A grade 3 is a purulent infection, mixed cocci and rods, so just mixed bacteria. And a grade 4 is a purulent discharge with pure rods, and these are of course the most nasty, the most difficult to get under control. You'll very rarely see yeast and rods together, and also note that pure rods is not the only form of grade 4. A beta hemolytic strep infection can be just as nasty and just as difficult to control as a pure rod infection. So for the drug spectrum, I've listed the bacteria that are most commonly involved in dermatology here. So of the gram-positive aerobic spectrum, staph and strep are the most common. But we have to remember that strep can act as a facultative anaerobe, so we do need to cover the gram-positive anaerobic spectrum also when we identify strep, which would be gram-positive cocci in chains on our cytology. For our gram-negative aerobic bacteria, Pseudomonas, Proteus and E. coli most common. Gram-negative anaerobes are very uncommon in dermatology, so we don't normally need to worry about that part of the spectrum. For cephalosporins, the first generation, they have gram-positive coverage, both the aerobic and the anaerobic spectrum. And the third generation also have activity against gram-negative aerobic bacteria, making, of course, the cephalosporins fantastic for dermatology, covering, as they do, a lot of the involved organisms. You will receive notes from this after if you don't want to copy this down. For the aminopenicillins and the beta-lactamase inhibitors, such as amoxiclav, we have great gram-positive and aerobic and anaerobic coverage. They do cover the gram-negative anaerobic spectrum, but they don't cover the gram-negative aerobic spectrum. So we're certainly missing out on coverage of Pseudomonas here. The fluoroquinolones cover only the aerobic spectrum, both gram-positive and gram-negative. They do not cover the anaerobic spectrum at all. And it is something to bear in mind because certainly one of the risk factors associated with the development of necrotizing fasciitis, for example, is the use of a fluoroquinolone early in the stage of treatment. Not that that's likely to be a case with ears and dermatology, but just a recent study demonstrated that the use of enofloxacin was a risk factor in the development of necrotizing fasciitis, which is hemolytic strep group G. And in this case, it's not only that it's not covering the spectrum when strep is acting as a facultative anaerobe, but it actually changes the nature of the bacteria, making it more virulent for that disease. Just something interesting to note there. For the aminoglycosides, gentamicin, framicete and neomycin, we have great aerobic coverage, but again, not much anaerobic coverage. Metronidazole is very rarely used in dermatology, if at all, and has only anaerobic coverage, and it also has activity against protozoa. Fusidic acid is an antibiotic that covers the gram-positive spectrum, both aerobic and anaerobic. And the other antimicrobial agents to be aware of, the lincosamides and the macrolides, are both bacteriostatic, not bactericidal, mostly covering the gram-positive spectrum. We have the antifungals, miconazole in the azole group and nystatin in the polyene antifungal group. For our antiseptics, some of those that are commonly used are chlorhexidine, which is in Malaseb, Pyohex and surgical scrubs. It's broad spectrum, so it covers both gram-positive, gram-negative, and has some antifungal activity also. Faster kill rate than iodine, and is bacteriostatic or bactericidal depending on the concentration that's used. Cetrimide has a narrower spectrum covering the gram-positive spectrum only, does have some activity against fungi, yeast and protozoa. And then we have the class of iodine, betadine, very broad spectrum again, gram-positive, gram-negative and antifungal. Some other considerations when we're selecting topical treatments. One is what sort of base it's in. So a shampoo base versus a surgical scrub is something to consider when we're talking about the treatment of hotspots, for example. It'd be more appropriate to use a lathering shampoo base to lift crust and be more gentle on the skin than to scrub with a surgical scrub. Surgical scrubs often contain an alcohol component as well. We want to think about what the active ingredient is in combination with. So certain agents are synergistic. Miconazole, for example, and chlorhexidine are synergistic, and alcohol is synergistic for cetrimide and chlorhexidine, but antagonistic for iodine. So there's those sorts of factors to consider also. We want to know whether the antimicrobial that we've chosen is going to work as well in the patient as it does on a culture plate. Certainly some look great and have great sensitivity when tested in vitro, but then fail to act in vivo. And often this is because of the presence of organic matter that can deactivate many antimicrobials. We want to look at whether the solution that we're using is an irritant, and that can depend on the active ingredient being an irritant or the formulation being an irritant. So we're often talking about very sensitive damaged tissue in dermatology. We want it to be as low irritant as possible. And finally, we want to think about residual action. When using topicals, we can't be applying them every second of the day. We need to know how long does the action of the active ingredient last, and therefore how often do we need to be applying this treatment. Now in the case of something like the Fusi range, so Canoral, Canoptil, Fusiderm, Isoderm, they certainly have been demonstrated to be true twice daily dosing because we know that the active ingredient remains above the required mean inhibitory concentration for greater than 12 hours. This is a study here that looks at the residual antibacterial activity of shampoos. So if we look at 2% chlorhexidine and 2% miconazole, and that was actually Malaseb that was used in the study, the larger the number, the bigger the zone of inhibition and the more antibacterial activity, and had significant activity right out to day 17. But of course we get the best results when we're using it even at less intervals than this. And this one here, 3% chlorhexidine, which is Pyohex, excellent zones there. And when we use it in combination with a leave-in conditioner, it has an even longer residual activity. So we want to think about how often we should be using them in conjunction with the benefits and the negatives. We don't want to be shampooing daily. We can be shampooing twice a week and getting excellent residual activity there. A couple of cases to go through to integrate what we've talked about with the techniques. This was a West Highland White Terrier with chronic foot disease over the course of several years. We can see that we've definitely got some interdigital erythema, some discharge and some crust around the nail beds there. So we worked through the steps of cytology that we've already discussed. Firstly, we did cytology on the deep purulent sinus tracts, mostly gram-positive groups of 4 bacteria, so we know that they are most likely to be Staph pseudointermedius, and lots of degenerate neutrophils. When this dog was put on antibiotics, long courses, 8 weeks or greater, there was a partial response, but it never completely resolved. So a culture was run, antibiotic resistance was not the problem. This dog was scraped probably 5 or 6 times every time it came in, and Demodex was never found. There were some yeast present on cytology. This dog had a history of chronic atopy that became more difficult to control over time. So we've done what we can for cytology. We then move on to a biopsy, and this dog had cutaneous lymphoma of the feet. So it just goes to show that we don't want to stop with our diagnostics. We keep going until we've got a result. And then the update is things change over time. So a year after treatment for the cutaneous lymphoma, the dog had improved dramatically on treatment, was looking fantastic, started to get worse again. We decided to scrape, because even though we had negative scrapes last time, things changed, and this time we found Demodex. So just because you've scraped or taped or even biopsied, never assume that it can't then be a different condition down the track. Question in this case, was it Demodex the whole time? Unfortunately, the histopathological appearance of Demodex and cutaneous lymphoma are very, very similar, minus the presence of a Demodex mite. So it may have been that this was misread out, but we don't think that was the case, because it improved with treatment for cutaneous lymphoma, which is immunosuppressive, and then, with the decreased immunity, perhaps the Demodex thrived in this case. So I like this one because we so commonly look at red, irritated feet and assume a contact allergy or something else, when this was a much more serious condition that required consistent diagnostics to reveal. A more simple case, the skeleton from the beginning of the presentation. So it was an RSPCA case, significant alopecia, thickening of the skin and pustules. Cytology revealed malassezia, cocci in groups of 4, we know a staph, and of course he was riddled with Demodex. The treatment that we chose was Malaseb for the malassezia. He was on topical Amitraz and once to twice a week, and daily oral ivermectin. This case was from several years ago. We do have other options for the treatment of Demodex now. I will say at the Dermcare clinic though, we often see the ones that have failed all the other new treatments, and daily ivermectin and topical Amitraz is something that we do need to resort to in some cases to get things under control. And of course, being Demodex, we assumed a folliculitis, which is a deeper pyoderma, so this dog went on to systemic antibiotics as well. We don't have an after photo, unfortunately, but he did look good. But that one was lost to follow up with the RSPCA. This is I just want to run through some of the products that RxVet distributes. The Fusi range consists of Canoral, Canoptil and Isoderm. So they have the active ingredient of fusidic acid, common to all, and we know that fusidic acid, as we looked at in the earlier slide, covers the gram-positive spectrum, both aerobic and anaerobic, so excellent activity against staph and strep, even when acting as a facultative anaerobe. So Canoptil is the fusidic acid in a viscous gel. As I mentioned before, fusidic acid does persist above the mean inhibitory concentration required in ocular tissues for greater than 12 hours. It is one of the few eye ointments that truly is twice daily dosing. Some of the others that are available, certainly in Australia, we know need to be dosed at 8 times a day to maintain MICs. The additional benefit of Canoptil is that it does penetrate the aqueous humour. So if you have a penetrating wound of the eye, it's something you can apply topically to be effective in that way as well. And great for canine conjunctivitis. We know that greater than 80% of the organisms involved are staph and strep, which fusidic acid has great coverage against. Isoderm is fusidic acid and betamethasone in a carbamazole base. It is non-stinging. It's also non-occlusive. It's breathable. It achieves deep penetration, so even for those hotspots that are deeper, and again persists greater than 12 hours above the required MIC for the most likely bugs that would cause a pyoderma, which of course is Staph pseudointermedius. Canoral is one of the most broad spectrum ear products on the market. So it has fusidic acid, framacetin as another antibiotic, nystatin for yeast, prednisolone as an anti-inflammatory, and the sesame oil base is effective against ear mites as well. So if we look at all the possible causes of otitis externa, we have, if you remember, that the spectrum that dermatological bacteria tend to fall under is the gram-positive aerobic and anaerobic, and the gram-negative aerobic. Fusidic acid covers both gram-positive aerobic and anaerobic, covering our strep, and framacetin covers gram-positive aerobic and gram-negative aerobic, so we've covered the antibacterial spectrum there. We've got nystatin for yeast, prednisolone as an anti-inflammatory agent. One of the most important things in getting otitis externa under control is dealing with the inflammation and opening up the canal. And the sesame oil based is effective against ear mites as well. Moving on to the Dermcare range specifically. Of the shampoo and flush range, we have Malaseb, Piohex, Alavine, Natural and Odaflush. So Malaseb is appropriate for seborrheic dermatitis, which is the greasy, smelly dog that you smell coming into the clinic before you see it. Thankfully, I don't think we see dogs as severe as this these days. We do tend to get onto seborrheic dermatitis before they become completely alopecic and lichenified. And it's effective, the greasy, smelly dog or seborrheic dermatitis usually involves both Malassezia and staphylococcal infections. So Malaseb has chlorhexidine and miconazole, and it's indicated as a topical keratolytic. It's antibacterial, antifungal and antipyretic. So it's registered for the treatment of primary and secondary seborrheic dermatitis, and it's an aid in the treatment of dermatophytosis as well, and it's registered for use in both cats and dogs. Doesn't have any dyes or perfumes. It's unscented. It doesn't cover up the smell associated with seborrheic dermatitis, but it removes abnormal sebum, kills and removes the pathogens, and cleans and reduces malodor. For dermatophytosis, it is an aid in the treatment. There's a study that demonstrates that the use of Malaseb topically in conjunction with a systemic is more effective than just using a systemic or just using a topical alone. What it does is it sterilises the spore on the coat so that when that spore is shed into the environment, it is no longer infective. So it's fantastic to use for in-contact animals and infected animals. We recommend its use twice a week during the course of treatment for ringworm, preferably until we do get a negative culture. It's good for shelter environments. No one likes to bath cats, but there's a few tips that we use at Dermcare. I remember when we had 100 cats at the Queensland RSPCA to do. The tip that we always give people, and that you can give your clients as well, is to use the 3-bucket technique. So the water should be heated to body temperature. Cats much prefer that, we found. The first bucket is just water. The second bucket is Malaseb and water, and the third bucket is just water. And we simply dunk them rather than trying to use running water. So it can be done quickly. The ideal contact time, of course, for Malaseb is 10 minutes. Contact time is important with the effectiveness. However, there are good results even at shorter time frames than that. So we want to dunk the cat to get it wet. We've got a scruff by this stage. We dunk it into the Malaseb, lather and hold, and then into the final bucket and go. We do want to make sure that they're rinsed clean as much as possible. Canine pyoderma is usually identified with pustules, pimples, or recurrent hotspots. This is a picture here of a poor golden retriever with some terrible hotspots there. This is what we call a staph collarette. That's a ruptured pustule, often mistaken for ringworm. That's not the case. And of course, we can see them here in the earlier stages, rupturing pustules that have become scabbed over the top. It's a Staphylococcus pseudointermedius infection. Piohex is appropriate for this. In Malaseb, the concentration of chlorhexidine is 2%, because that's the best for synergy with miconazole. But in Piohex, the concentration of chlorhexidine is 3%, and that's been demonstrated to be more effective than 2% chlorhexidine on its own, or even 4% chlorhexidine on its own. 3% is accurate there. It's a topical antibacterial shampoo, and it aids in the treatment of superficial dermatitis and secondary bacterial infections associated with Demodex. Why would we use Piohex when you could just put everything on Malaseb and it covers both of them? Well, the answer is if you don't need miconazole, don't use it. It's very expensive. It's also not an appropriate way to use antifungals. We don't want to use them if they're not required. And again, we know that when chlorhexidine is used on its own, 3% is the appropriate concentration, not 2%. Alavine contains, it's for irritated skin, contains colloidal oatmeal and aloe vera. Colloidal oatmeal is renowned for its ability to hold moisture and relieve dry, itchy skin, and aloe vera is a potent natural anti-inflammatory. And finally, natural shampoo is a general all-rounder. It's hypoallergenic, soap-free. It is very economical, you don't need much. For all our shampoos, the recommended amount to use is 1 to 2 mils per kilo. Probably 2 mils per kilo is more appropriate in a thicker coated animal. If you find that you're not achieving enough of a lather with the shampoos, add more water, not more shampoo. These are high quality shampoos that aren't loaded with water in the bottle. You need to add water to achieve the required lather. Natural has a coconut oil base, so a really pleasant coconut smell, and can be used in dogs, cats, horses, any age. Because it's soap-free, it is suitable for use in conjunction with flea rinses, spot-on flea treatments, but we do recommend following the manufacturer's advice of the actual anti-flea product. And our most recent product to come to New Zealand is our Otaflush ear flush. Otaflush is a lot more than just an ear cleaner. So it does contain tris-buffered EDTA and an antiseptic called PHMB, which has a great spectrum of activity and is very gentle on inflamed tissues. You might have heard of tris if you've ever had to deal with a resistant Pseudomonas infection, and the recommendation comes back from the lab to pre-treat the bacteria with tris. Tris is not available in any other form. When it was available, the issue with tris is that it used to take a long time to work. So actually tris needs to be in contact with bacteria for up to 30 minutes to be effective. So because we've synergised the tris-buffered EDTA with PHMB, the activity time is only 15 seconds. So if you have a resistant Pseudomonas infection, you can flush the ear with Otaflush. The tris acts by chelating calcium and magnesium out of the bacterial cell wall to destroy its defence mechanisms. Let the dog shake out the excess, straight in with your medicated drop over the top. There's no wait time with this product, which is better for client compliance. It's completely non-sting, it is pH neutral, and in Australia certainly it's the only product on the market with proven middle ear safety, so it can be used even when the eardrum is ruptured. We tested that in a study comparing it to saline, and the BAEP hearing tests that were done showed no clinically significant difference between the use of Otaflush and the use of saline, and in fact the dogs that were on the saline flushes had more ear infections during the course of the study. So how does it work? I've already mentioned that it can pre-treat the bacteria, but it also has mild surfactants to remove debris in the ear canal, which allows for better penetration of your medicated drop. It has its own antimicrobial activity against Staph, Proteus, Sude, E. coli and Malassezia, which is great, but in cases of active infection, we certainly always recommend using it in conjunction with a medicated drop like Canoral. Overall, it reduces the mean inhibitory concentration required for antibiotics, and this means that where we've previously had something classed as resistant, it can come back into the sensitive range, and antibiotics you thought you couldn't use in this case anymore can now be used in conjunction with Otaflush to treat conditions such as Pseudomonas. It's great for in-clinic ear cleaning. You can use it in the consult room because it's not going to sting a dog's ear in front of the client. As I mentioned, great as a pre-treatment before antibiotic topical therapy. If you have a resistant case, often classified by a purulent discharge, you want to be using your Otaflush before every time you put your medicated drops in. If it's just a waxy infection, it's still really useful to use Otaflush, maybe 2 to 3 times a week during the course of treatment to remove debris, but also for its own antimicrobial activity, getting a double whammy. Once you have ear infections under control, then the owners can flush the ears at home once a week with Otaflush to remove debris, reduce microbial numbers and prevent the recurrence of Otitis externa. This is a pre and post. This was about 1 minute apart on video otoscopy using about 3 syringes full and a flushing tube with Otaflush. So it's a great cleaner. It's not something that will literally liquefy hard wax plugs. That would require quite strong chemicals, which of course would mean we probably wouldn't have middle ear safety, but it's fantastic for removing a lot of debris, and gentle flushing with Otaflush with its mild surfactants will help remove that more harder wax that's built up as well. And that's the end. Yep, good, thanks. Anyone have any questions? Yeah.
Yeah, on the Otaflush bottle, I think it says don't use for longer than a week.
Yeah.
Is that because you've just done safety tests for a week and we don't know if it's...
Well, To get a safety claim, you have to test for, depending on the product, 3 to 5 times as long as you're allowed to claim for. So the safety study that was done for the middle ear case was Otoflush 3 times a day for 6 weeks. And that allows us to claim about a week of safety. In that study, approximately 2 dogs out of the study did end up with a small amount of overhydration of the canal, but they were being flushed 3 times a day, which is not what we'd do. Our recommendation is if you need to use it for longer, and often you will in those really really resistant cases, that you start off using it twice a day in conjunction with your medication for at least a week. As the amount of discharge drops off, and it should if you've selected the right polypharmacy, drop down to once a day, then every second day, and so on. So we're tapering the treatment. But we've certainly used it for 8 weeks and longer without an issue. But of course, the safety claim has to come from the studies that were done. But if you can taper it off, you'll avoid any of those overhydration issues. Overhydration is it's not as common as people think it is. You can identify it by having a cytology slide, which demonstrates no bacterial presence, small, tight, inactive neutrophils, but the ear canal is quite painful and steamy almost, with a whitish discharge. If you get that, hold off any topicals other than something with a nice strong steroid. We use a lot of Otomax once a day for 5 days. It will settle it right down, then back onto, say, a once a week regimen of Otoflush to prevent infection from coming back. Any other questions?
All right, cool. Well,
awesome.
Thank you very much, Susan.
No worries.
Great.
Thanks.